Shelbourne Knee Center podcast, and tonight we're going to be talking about another study that we've completed at Shelbourne Knee Center, and it relates to an osteoarthritis topic. This was done with Scott, my co-host, who is here tonight as well, and also included as authors Rachel Slavin, who is no longer a physical therapist at our office, but was at the time, and also with Dr. Shelbourne, and it's titled Rates of Total Knee Arthroplasty Based on the Location and Severity of Knee Osteoarthritis. So we're going to talk a little bit about not just non-surgical treatment of knee arthritis and how we can do with avoiding surgery or progressing to surgery, but whether or not it differs by compartment. Our last episode was with Mike Einbinder. He is a physical therapist and strength and conditioning certified specialist who is currently doing a residency at the University of Cincinnati. Worked a lot with the University of Cincinnati basketball team, and we had a pretty long discussion about PT residencies just in general and his experience with sports PT and basketball players. So Mike Einbinder was our guest on our last episode. Go back and check that one out if you'd like to hear about that topic. And we have a lot of content. We have over 30 episodes now in the queue. So if you'd like to go back and listen to those, feel free to. If you have positive comments for us, please make sure to look at those. If you'd like to hit us up on social media, we have Facebook and YouTube pages for the Shelbourne Knee Center podcast, and you can find us on Twitter and Instagram at the SKC Podcast. You can also email us at the skcpodcast@gmail.com.
And for tonight, as you mentioned, we have a project that we worked on looking at the rates of total knee arthroplasty based on the location and severity of knee osteoarthritis. And I think this is going to be a good episode, especially coming at it from both angles, both myself with the physical therapy perspective and yourself as the surgery perspective, and looking at what types of patients and what compartment and severity of those patients go on to have a knee replacement. And I know this originally stemmed from more of the clinical questions. We did a project years ago looking at the results of patients with osteoarthritis and who went on to have a surgery, and we really lumped them all together. And the conclusion that we made with that study was that about 25-30% of patients in that cohort went on to have surgery. And just with obvious clinical experience and seeing these patients, we know that it might not be the case for everybody. And when we get these patients in our office and we see them and you diagnose them with osteoarthritis and send them to therapy and work with myself, and patients say, well, what are the odds of me having surgery here, and possibly how long is it going to take before we know this answer? And we always rope off the 25-30%, but that's really in a global sense. So we really wanted to nail that down and say, well, it doesn't matter that it's on the medial side or lateral side or patellofemoral compartment and what severity it is. So that's really the clinical reasoning that we went on to start this study. So, and we'll get into that study in here just a little bit. But before we get started, Dr. Brenner, could you kind of recap? I know we've had episodes about non-operative OA if you want to go back and listen to those, but just in general, the treatment philosophy that you have for patients when they come in with with osteoarthritis.
Well, for those who haven't listened to our previous episodes, we've talked a lot about knee rehab for osteoarthritis in previous episodes. We had a multiple part series where we talked with Dr. Shelbourne and we talked with one of our physical therapists as well. So feel free to go back and go through those episodes if you're interested in the nuts and bolts of what we do for non-surgical treatment in EOA. But just in general, we really try to work hard to keep people out of the operating room if at all possible. And as a surgeon myself, a lot of people I think that are my friends hear me say that and say, why would you want to do that? We're surgeons. We like to operate. That's somebody else's responsibility. But as part of our multidisciplinary approach that we have at our office, we like to try to get people better non-surgically in a variety of different ways. Some of that is from injections and medicines, of course. But a big part of that is the therapy process and figuring out, are there functional improvements that we can make with our patients that can lead to improved outcomes and hopefully even avoid surgery. But then we're trying to look at this in a little bit more granular fashion to try to find out not just if somebody has an arthritic knee, how often do they go on to surgery, but are there differences depending on where the osteoarthritis is? And just as background, before we started this study, I think our impressions were first that the majority of the patients, the largest group of patients were patients with medial compartment osteoarthritis, and then the lateral and patellofemoral ones were less common. And an observation that Dr. Shelbourne and myself have both made, that those patients who have medial compartment arthritis are often a lot stiffer, maybe than the lateral compartment ones. The lateral compartment ones don't seem to be quite as stiff. They sometimes can get weak, and they have definitely an abnormal gait. They tend to kind of waddle a little bit, but they do and throw their knees into a little more extension with walking. So some functional differences in the way that patients use their extremity with regard to rehab progression that were different in the different compartments. And then, of course, with the patellofemoral compartment, we assumed that those people would be less likely to go on to surgery for a couple of reasons. One being that it's not the main weight-bearing compartment of the joint. So with normal walking, a lot of times people with primarily patellofemoral arthritis don't hurt so much when they walk, like the people with the medial and lateral compartment. Secondly, they also don't have any angular deformity, since it's not on one side of the joint or the other, leading to angular deformity. And finally, because it usually only bothers them with specific exercises and specific activities, such as things that are loaded with their knees in a bent position. So getting up and down out of a chair, getting up and down off the toilet, going up and down stairs, things like that, or specific activities that bothered patellofemoral patients that maybe are a little bit easier to avoid or compensate for. So with all this in mind, when we start to think about this in a little more of a granular and specific fashion, we started to wonder, not only can we tell patients, X percentage of the time you're going to go on to surgery, but can we maybe hone in a little bit more on that specific to the compartment where their arthritis was the worst, and find whether or not the eventual progression to surgery was more or less common depending on where their arthritis was located.
So when you first see these patients and you're working them up and you diagnose them with osteoarthritis, or maybe even before that, they're obviously seeing you because of pain. Some patients come in and they have previous x-rays. They know they have a diagnosis of osteoarthritis, but some don't. So how do you go about the treatment or the patient education for those patients where they come in and they're hurting and maybe they don't know they have osteoarthritis? Or really, how do you handle that when you tell them, well, you're starting at XYZ and you want to progress them to a certain level or divert more to a surgery discussion? What's that look like in the clinic?
Well, I think one of the big challenges early on in dealing with these patients is trying to match up their symptoms with what their radiographs show and what their function is like. So, interesting thing that we found in previous studies that patients with mild, moderate, or severe arthritis on X-ray, they often come in with similar scores on the KOOS. When we give people the KOOS survey when they first come in for their first visit, then we broke those down by whether patients had mild, moderate, or severe arthritis. The mild patients came in at about 50 out of 100. The moderate patients came in at about 50 out of 100, and the severe patients all three groups came in at about 50 out of 100 on the KOOS, which just goes to show that it's not necessarily a specific level of arthritis that causes people to come in. It's more of a specific level of symptoms, regardless of how much arthritis they have. And then also we have to put that together with their functional limitations as well, in that side-to-side differences matter a lot. If patients come in with two arthritic knees, sometimes they'll have one knee that hurts and one knee that doesn't. And often the one that doesn't hurt is the knee that has good range of motion, good strength, and superior function of the two. And the knee that's painful and is the knee that they're complaining about is often stiffer, weaker, and deconditioned. So, putting that all together as a background is kind of what drew us to this, that we started to think, well, if severity doesn't necessarily predict progression of symptoms and how severe things are, and that the same patient can have two very arthritic knees and have very different symptoms depending on their function, then is it possible that these patients could react differently and progress through this treatment protocol, either to surgery or to resolution of their symptoms differently based on where the arthritis is located? And I think that leads nicely into this project that we're talking about today, Scott. So, give us a little bit of background. That I guess we've kind of already covered some of it, but a little bit of what the background on this study is and what the purpose and hypothesis of this study was.
Well, you hit the nail on the head with the rationale. And, we talked about the original rationale being more from the clinical side, where patients were asking us the question of what are the odds that I'm going to go on to have a knee replacement? And we wanted to get a little more granular with that answer and be able to really pinpoint and have more accuracy with our answer in terms of your odds of going on to a knee replacement is this and at what time. But also, as you mentioned, the discrepancy between radiographic findings and clinical symptoms is also very apparent. Like you said, patients are coming in at the initial visit usually around a 50 out of 100 points on the KOOS score, and that's regardless of the severity of osteoarthritis. And we're typically able to see patients progress pretty well despite having severe arthritis or moderate arthritis or at the lowest form, mild arthritis. So really that was the impetus of the project. We wanted to not only answer the question of what the likelihood of patients were to go on to have a knee replacement based on the severity and location of OA, but we also wanted to track that KOOS score over time and see if that differed based on the fact that they had a knee replacement or not. And from a hypothesis standpoint, before we conducted the study, we kind of figured that there would be differences between total knee progression to total knees based on the location of osteoarthritis, whether it be medial, lateral, or patellofemoral. And then obviously, I think we would all agree that the more severe the arthritis would be, that the higher rate of total knees would occur.
Well, let's dig into the methods on this study. How did we come up with this patient population? How did we separate them? And what kind of outcomes did we look at?
So at the Shelbourne Knee Center, we have a longitudinal study that's specifically looking at the outcomes for non-operative treatment for osteoarthritis. So at the clinic, when they're diagnosed with osteoarthritis, we have either a clinic member or a research team member consent them to the study, and then we are able to track them over time throughout their course of non-operative treatment to look for factors that lead to a successful course of treatment or end up going to a knee replacement. So we ended up between 2013 and 2019, 337 patients that were diagnosed with osteoarthritis. And again, we're enrolled in that study I was talking about, and we divided them into 9 groups. We wanted to divide them into mild, moderate, and severe osteoarthritis, and for the compartments of medial, lateral, and patellofemoral. So we have mild, moderate, severe for medial, lateral, and patellofemoral. So we ended up coming up with 9 different categories. So with the groups of the severity and location of osteoarthritis, regardless of that location and severity, the patients went through a pretty similar rehabilitation program where we focused on range of motion first, followed by strength training, and then eventually trying to get the patients back to their activity level. If at any point their progression stalled and they wanted to pursue a knee replacement, we ended up having them see Dr. Benner again and then having that discussion of is a knee replacement right for that time. But that's basically the progression that they would go through with range of motion and then strengthening. And then for the study purpose, we further categorize patients as having a total knee yes or a total knee no. And the nice thing about this retrospective study is we already knew that answer going forward. So we followed these patients for up to 8 years, and we did call them on a regular basis if we haven't seen them in a while to see if they've had a knee replacement. So we've had a pretty updated list for this 337 patients, again, up to 8 years from the start of treatment. And we already categorized them as total knee yes or total knee no. And then from an outcome standpoint, we had them do the KOOS like we talked about, and we wanted to have that at the time we enrolled them, and then 1, 3, 6, and 12 months after enrollment.
Once we came up with that population, Scott, how did we put it to the test from a research perspective, and what questions did we try to answer?
Well, the first and main question was we wanted to figure out what the rate of total knee was based on, again, the location and severity. So between those 9 groups, we came up with the total knee yes group, or the percentage of patients that went on to have a knee replacement based on the location and severity. So for this one specifically, we wanted to test them and to see if the rates were different among locations and if the rate was different among the groups. And if you specifically look at the medial compartment, which, as you had mentioned, is going to be the highest percentage of patients having osteoarthritis, we want to statistically look if there was a difference in rates based on patients having mild, moderate, or severe medial compartment arthritis. And we did show that there was a statistically significant difference in terms of the rate of total knees based on those 3 groups, with the mild being the lowest at 9%, moderate second at 20%, and as you would imagine, the severe medial group having the highest rate within that group or within that compartment at 43%. And then from there, we also wanted to look at the other groups, whether it be lateral and patellofemoral, again, comparing mild, moderate, and severe. And the lateral group as well as the patellofemoral group did not show to have a statistically significant different rate. For example, the lateral groups at the mild was 0% going on to have a knee replacement, moderate lateral 3%, and severe lateral 17%. So you're talking 0, 3, and 17 for the three groups, but that was not statistically significantly different. And then similar for the patellofemoral group, it was not statistically significantly different, with the mild and the moderate groups both having 0% going on to have a knee replacement, and the severe patellofemoral group going on to have a knee replacement 9% of the time. Now, the other part of the analysis we wanted to look at was specifically look at that severe group. That's typically the ones that you're going to think of that's going on to have a knee replacement at the highest rate. So we wanted to see of the severe groups within the medial, the lateral, and patellofemoral groups, which ones had the highest rate and wasn't statistically significantly different. And we were able to determine that there was a statistically significant difference in that rate, with the highest rate belonging to the severe medial group at 43%, followed by the severe lateral group at 17%, and then lastly with the severe patellofemoral group at 9%.
And that's really the crux of what we were getting at, is those people within the severe group, does the location of the arthritis matter? And I think we showed a pretty clear difference that with the severe medial group, it was almost 50-50 whether or not people went on to having surgery, versus the lateral side, a much smaller percentage, only 17% of people with severe lateral compartment arthritis going on to surgery. And I personally was kind of surprised by that, because it seems like from a deformity perspective, the people that most notice their deformity with osteoarthritic knees are the people who have severe lateral compartment OA, because it makes them knock kneed. It makes their involved knee kind of run into the other one, or sometimes if they have two valgus knees from lateral compartment arthritis, I've had patients that almost have to swing their legs around when they walk so they don't run into the other knee, versus the varus knees don't do that, and the patellofemorals don't have any angular deformity. But that, the numbers are what they are, that for whatever reason, the lateral compartment ones are less likely to progress. And then the severe patellofemoral ones, less than 10%. So those are some numbers that I kind of have, rounded off. The raw numbers are 43% for severe medial progressing to total knee, 17% for severe lateral, and 9 for severe patellofemoral. I've almost kind of rounded those off when I talk with patients that, if you have medial compartment arthritis that's severe, probably about a 50-50 chance that you end up having surgery, versus if it's in the lateral compartment, about 15 to 20%, and about 10% for severe patellofemorals. So, yeah, I mean, this study really did answer an important question for us. And it's one that I use commonly. It's one that I use in clinic all the time to counsel people on how likely it is that they're going to progress onto surgery. As we've talked about in previous episodes, a lot of these patients just assume that if they have bone-on-bone arthritis that I must need an operation or I have to live with it. Those are my two options. But in reality, there is a third arm where we can try to make people better non-surgically. And, when people say, well, for my specific type of arthritis, does it matter where the arthritis is located? Does that have an impact on whether or not I might avoid surgery? And the answer is pretty clearly yes from this study. And we do use that to counsel our people.
Another interesting part of this study was looking at the progression of KOO scores over time. And again, I mentioned that because of the retrospective nature of this study, we're able to know the answer for this cohort of whether they had a knee replacement or they did not. And then again, we can look back, see if there's any interesting factors that may have led to that outcome. And when we broke those patients down into total knee yes and total knee no, interestingly enough, the patients came in with a very similar KOO scores. And like we talked about with the severity being mild, moderate, severe, they usually come in with about a 50. That really goes for everybody. The patients that eventually went on to have a knee replacement, regardless of time frame of which they went on to have surgery, start off about a 50 on the KOO scores. And those that did not have a knee replacement and were able to treat this osteoarthritic knee non-operatively also start off about a 50. And then with our non-operative treatment program, after about a month, and we'll put this graph up on the social media platform so you can be able to see this visually, but you'll notice that even with the total knee yes and the total knee no group, both groups improve quite a bit in the first month. They go from about a 50 in the total knee yes group goes to about a 60, whereas the total knee no group goes to about a 65. Interestingly enough, the total knee no group goes from a 65 up to a 70, whereas the total knee yes group goes from about a 60 down to a 55. So you do see these graphs seem to divert between the 1 and 3 month time point. And we looked at that statistically, and we were able to determine that patients that were able to plateau or regress between 1 and 3 months were almost 5 times more likely to have a knee replacement compared to those that improved in the same time frame. So we do like to use this statistic clinically because patients will ask us the question all the time that they have medial compartment arthritis, which, like you had mentioned, is between 40 and 50% of going on having knee replacement. What makes them that 50 and what does not make them that 50? So we did that added analysis to be able to help with some of those answers, and we're able to determine that between months 1 and 3 seemed pretty pivotal. And if patients were able to continue to improve, it was more likely that they were not going to have a surgery. However, if they plateaued or regressed in that same time frame, the odds are against them, and they're more likely to have a knee replacement.
Yeah, those time frames have become important to me from a counseling perspective as well. When people say, honestly, a lot of patients are skeptical when I tell them that they have severe arthritis, bone-on-bone changes, show them the x-rays, et cetera, and then tell them that they don't necessarily need surgery. Sometimes I get some pushback from a lot of patients are relieved, but a lot of them give me some pushback on, but I thought you said I was bone-on-bone. How's that going to get better? And how long am I have to do this before we throw in the towel and decide that it's not working? And because I think people have in their mind that I'm going to say it's going to be months or years before we reassess things. But this data and other data that we've reviewed on previous episodes has shown us, if you get better in the first month to 6 weeks, if you're going to get better, you'll probably get better in the first month to 6 weeks. And if you do get better in that first month to 6 weeks, then if you can maintain it from there to the 3 month mark and beyond, then I think it's something that may be more long-term sustainable versus if you don't make as much improvement in the first 6 weeks, you maybe go backwards, maybe an injection starts to wear off, maybe medicine starts to be less effective at that, 6 week to 12 week time period, and you start to plateau or get worse. That's where we can say, then, I think we've given it a good enough time period, and it's just not going to happen for you. But again, another initial time point that showed not really any difference between people who progressed onto surgery and those who did not. I have a lot of people that come in, well, but you don't understand, my knee's really bad, so doesn't that mean I'm not going to get better without surgery? No, it doesn't. The severity of your symptoms doesn't necessarily mean you can't get better. And then when they look at the x-rays, well, my arthritis is so bad, doesn't that mean I can't get better? No, it doesn't mean that you can't get better. There are lots of people that we have that have severe arthritis and that have severe symptoms that think that they're on the end of the continuum that is least likely to get better. And the answer is that that's just not what the data shows us. The data shows us that, really anybody can get better and anybody may not get better. And we just have to let the progression kind of play out and find out which of those buckets people fall into. So one quick note as we look at this graphically when we put this out, we do have a couple patients from the mild category progress on to surgery just in the medial group. The mild lateral and the mild patellofemoral group, those patients had 0% progression to surgery, and even the moderate patellofemoral 0% progress to surgery versus moderate lateral only 3% progress. So it was very unlikely that they were going to progress. But in the medial side, we had 9% of patients who had mild medial arthritis. When we went back and looked at those patients were usually people that had avascular necrosis or stress fracture injuries that progressed relatively quickly due to, as I'm sure we've all dealt with, the kind of stress insufficiency injury to the medial tibia or medial femur or both, where they have a relatively mild amount of arthritis, but their symptoms increase significantly in relatively a short time period. and we find them to have stress reactions or stress fractures of the or insufficiency fractures of the medial femoral condyle or the medial tibial plateau. Those patients do sometimes progress rather quickly, and that joint space goes from being mildly arthritic to moderately and over to severe, and end up requiring surgery within a relatively short period of time. So I think when people look at that, they may think, why are they operating on 9% of people with mild arthritis? And the reason is because they have other extenuating circumstances that lead to quicker progression.
From a surgical decision-making standpoint, jump one category above that. So now we're talking moderates, whether it be moderate lateral or moderate medial or moderate lateral. That's 20% and 30%, with medials being higher at 20. What would you say is, or I should say, are those 20% patients in a similar situation as the milds you were just talking about, where it was some type of insufficiency fracture or avascular necrosis, or what? We've been to meetings where surgeons put up pictures of x-rays that don't look like the typical severe osteoarthritic knee that goes on to surgery. Now, my question for you is mainly for the moderates. I know you explained the milds, but with those moderate categories, is that somebody that typically is going to progress to severe OA, or is that still the variety that is the insufficiency fractures and avascular necrosis?
A couple things on that group. Some people, obviously within each category, it's a continuum. So we kind of measure this based on, consider it mild if they have less than 50% joint space loss, moderate if they have more than 50% joint space loss but not complete joint space loss, and then severe if they've completely lost the joint space. Some of these people in the moderate category, some people that we list in the moderate category may have 95% of their joint space loss. That on one side they have 6 millimeters of joint space, and on the involved side they have a 0.5 millimeter when we measure it. So even though they're still technically moderate, sometimes these people are very, very close to having a severely arthritic knee, and it's not that much progression that needs to happen to tip them from moderate to severe. Sometimes we even just will operate on people who have who had what we consider a moderate grade of arthritis, if they fail a pretty significant length of non-surgical treatment. The other part of it is sometimes people just have symptoms that are above and beyond what we would expect from their specific stage of arthritis. So, even though we've shown that, it doesn't necessarily mean that people can't get better, there's still some differences on how often people get better depending on the degree of arthritis. And, sometimes the symptoms just seem out of proportion. Every once in a while, we have people that have moderate arthritis, but come in 2, 3, 4 visits saying, my knee is just killing me and it's not getting any better, and non-surgical treatment's not helping. And there just seems to be a disconnect between the amount of symptoms that the patient's having and what their radiographs look like. And in those cases, every once in a while, I'll get an MRI scan to see if maybe the arthritic progression and the chondral loss in that involved compartment is actually a little bit worse than what the x-ray shows it. And it does sometimes. Sometimes we'll have people that have mild to moderate arthritis who we get an MRI scan after, seemingly having their symptoms be out of proportion to their x-ray findings, and we'll find that they have more severe arthritis on an MRI scan. So I think those are a couple explanations where those moderate patients end up with surgery.
Well, I appreciate you giving some insight a little bit further into the results there. And that about wraps up this discussion on this research study that we did. I think the results are great. I think they have some really good clinical relevance to them because, again, we get so many patients that are curious as to what is the fate of their arthritic knee. And I think there's still a lot of unknowns out there, obviously, but I think this is one step closer to giving them more of an accurate answer over the blanket statement of the 30% or so go on to have a knee replacement. So I appreciate you going over the project and giving some insights.
If you'd like to hear more of our content, please check us out wherever you get your podcasts, on Apple Podcasts, on Spotify, on Google Podcasts, and lots of other avenues where you can find our previous episodes. We have about 35 other episodes, I believe, and would love you to check some of those out if you haven't already. Like I said, hit us up on social media, Facebook and YouTube at the Shelbourne Knee Center Podcast, Facebook and YouTube pages, Twitter and Instagram at the SKC Podcast, or email us at the skcpodcast@gmail.com. Make sure to follow us so you don't miss out on any of our content. And if you like what you hear, leave us a 5-star review. Take care, and we will see you next time on the Shelbourne Knee Center podcast.